Hi, my name's Mary May. I'm the Director for Data for Impact at UNAIDS in Geneva, and I'm going to give a presentation now on setting targets for long-acting injectable PrEP, so focusing on right now at the global level. We're just in the process of finalizing the global AIDS strategy for 2026 to 2031. In that strategy, we're recommending a set of targets that will help us get to the end of AIDS by 2030. What you can see in this graph already is a nice declining new infections as we got to the end of 2024, but then in 2025, we lost a lot of our funding. And so we've got a number of different scenarios that might go forward given this funding loss. What's important though is to look at what those targets are and figure out how we can reach those targets. And of course, some of them will affect what we're talking about right now on lenacapavir. We have already the ultimate goal is to get to a reduction of 90% reduction in new infections from our 2010 levels. We also have a focus on viral load suppression, so 95, 95, 95 treatment and testing and treatment targets, but also 90% viral suppression among people living with HIV. That will be really important to reach if we're going to end AIDS by 2030. We also have a target on people in need of prevention. And that's really about making sure that they're using prevention options. And so when we look at these targets over here, one is a situation, the first one there, the highest one, would actually result in increasing new infections over the coming 5 years if we reduce our prevention aspirations, if we reduce those targets. If we stay at 2024 levels, it just stays very flat there. If we keep pushing towards reducing or increasing our treatment services, we'll see that nice decline. But what's really important is looking at this last orange line, and that's meeting our 2030 targets, including this prevention targets, as well as some of the societal enabler targets. That's what we need to push countries to achieve, which includes this 90% of people using prevention services. Within that is a target on PrEP that we hope all countries will adopt to end the AIDS epidemic. So when we think about long-acting injectable PrEP as part of an effective prevention, we need to make sure we're thinking of it as part of an effective prevention method mix. So that optimal mix needs to recognize that we should be addressing the right populations, the right places where those services will exist, the right packages of services, and on the right platforms. And of course, we need to come back to prices always of the commodities that are required for those services. We need to move away from a single tool approach to something that's more sustainable for a full prevention system. So we can't just talk about lenacapavir here. We need to be talking about what are the options, including condoms, VMMC, behavior change, et cetera, to make sure that we've got the right prevention tools in place. From 2026 onwards, within the annual UNAIDS HIV estimates process, we'll be supporting countries to produce a set of routine needs estimates for prevention options. That will help countries identify the denominators of how many people they need to reach with those different commodities. Lenacapavir, of course, sits within that, and that's a very unique opportunity to really push down new infections with the benefits of lenacapavir and the long-term consistency of having 6 months of uninterrupted prevention. It's essential to add that to the package, but it needs to be optimally integrated. These concepts that I'm talking to here come from a new prevention framework that the Global Prevention Coalition is about to put out, so look for that in the future. In all of this, we're thinking of a way of looking at maximizing the impact of prevention, and we can start with looking at first the geographic locations and whether the different situations or what the incidence is in those situations. And as incidence increases, we need to be pushing up the coverage of our prevention services. So the targeted coverage of what we hope to achieve in terms of making sure people are receiving PrEP or that they're using condoms would go up as we get to the higher incidence. But equally important is, as we're at the lower level of incidence, is that we're focusing on the individuals within those populations, making sure the highest risk individuals are receiving those services that best meet their needs. So this concept of adjusting and going on a sliding scale based on the incidence level is really important going forward. What we've seen is in 2024, we still only had 3.9 million people using PrEP. Most of that's oral PrEP, but what could have happened to make those numbers get much closer is what we need to be thinking about as we're rolling out lenacapavir, excuse me. So things like stigmatization that occurred with some of the demand creation for oral PrEP. We need to keep that in mind with lenacapavir, and that's why we're saying focus more on geography and then come back and focus on your key populations. The second is demand creation, making sure people understand this is a great option for people at high risk, and I'll come back to some of those characteristics in my last slide, but thinking about that demand creation, doing it very carefully with the communities of people impacted. So bringing in adolescent girls and young women in the Uganda case, bringing in key populations to make sure that demand creation is appropriate and targeted correctly. And then finally, making sure the provider training is appropriate. So now let's think through what this means for PrEP targets and using this sliding scale. So we want to use HIV incidence within subpopulations and subgeographic areas and using their size estimates to predict what is needed for PrEP. And so this is a complex graph, so I'll take you through it slowly. But if you think about HIV incidence here on the left-hand side, and as incidence goes up, your reach and the coverage you hope to achieve with your PrEP should go up as well. So let's think this through. For example, for young people and adults, if you have an incidence rate of 2%, you'd want to have 80% of those young people and adults in that region, in that area, receiving PrEP. Now, 2% is very rare. We don't see that in most countries. We're seeing a lot more lower than that, 1%, 0.5%. If you have incidence below 0.2%, it's suggesting that you don't necessarily need to push PrEP. You have it as an option, but it doesn't necessarily need to be a major push in terms of a target. However, that's different than for key populations. And so again, if you have 2% incidence in your sex workers or men who have sex with men or transgender women, you want to be getting towards 80% coverage. When that incidence is lower, you'd go down in terms of your coverage levels here, as you'd see on the sliding scale. It's a little bit different for people who inject drugs, in that in many countries, that population is also using safe injecting equipment, and so there's no reason to push the PrEP higher there. One of the considerations we're taking is to consider a minimum threshold of about 5 people on PrEP for every estimated new infection. So in a country like Uganda, where there's about 37,000 new infections a year, that would get you up to about 185,000 people on PrEP, which is a major achievement. Would require a major rollout, but thinking through carefully where you're focusing, which populations will be important for that process. There are a number of tools that exist to help focus the targets based on geographic location, sex, and age group. In addition, behavior can be layered on to top of some of this geographic data here. This is a picture from Zambia, but it's showing the Naomi model estimates of HIV incidence. In this case, we've got it for both sexes, for 15 to 49, but you can change the age and sex here. And this is produced annually to understand where the high incidence regions are within a country, so that you can focus those services based on the populations in that region. We also have a tool, as I mentioned before, within Spectrum that will help you just identify and calculate the denominator. So how many people need different prevention services? You can then put this into a table by population group. And for each of the prevention options, again, making sure that you've got a full method mix. including injectable PrEP, long-acting PrEP, within a bigger picture of what's needed with higher counts instead of the higher incidence, because it'll be more impactful. So take that into consideration. You also want to focus on services. So where there is a clinic or where there is a services that's frequented by people who could benefit the most from lenacapavir, those clinics should also be considered. That UNAIDS modeling that I've mentioned already should be used to help identify these areas and populations, but do not restrict lenacapavir provision, especially among those who request it. Those folks will know best what their country. Thank you.
In the next count, we should be reaching 50 million people. We have had the HIV epidemic for 42 years now, and our response continues. Our epidemic, as well as the response, continue to evolve, but it can be described as generalized, severe, and heterogeneous in nature. However, it is concentrated in some population groups based on geographical areas and social demographic distribution. So the people living with HIV in Uganda, about 1.5 million. We have made progress. Our response has made progress since 2010. We have reduced the prevalence from 7.3 to 4.9%. New HIV infections have also dropped by 61% to now about 37,000 per year. AIDS-related deaths have also reduced by about 63,000 to now 63%. They have reduced by 63% to now 20,000 per year. And we have to put 85% of our people on treatment, meaning that we are 10% short of meeting the 95% target as per UNAIDS targets. But for women who are pregnant, we put 95% of them on treatment. Therefore, we are making progress. In terms of prevention, voluntary medical male circumcision, PrEP, PMTCT, and the other prevention coverages are increasing. And like Chair has pointed out, condom distribution is also ongoing, but we have not achieved the 80% target that we would wish to see. However, our response is very fragile. The epidemic control has not been achieved, and our response is largely donor dependent, with the vertical programs. And domestically, our budget meets a lot of fiscal pressures. We have so many needs with a small pass that can't meet all those needs. And we see lots of system bottlenecks. The human resource are not in places we want to see them. The laboratory system not reaching all the corners of the country. Strategic information, largely supported by partners. The supply chain, good, but also much dependent on donors. So that is the characteristic of our HIV epidemic and response. Next slide. Developing the sustainability roadmap. In developing the sustainability roadmap, this was not the first time. We have been working with the development partners. I think for over 5 years, we were working with the PEPFAR to develop the sustainability index assessment, which was intended to identify areas of strength and areas of weakness and build on that to have a sustainable response. But it was focusing on a few areas, and importantly, it was missing out the political component. The Global Fund, Sustainability and Transition Planning was largely focusing on financing. We have a commodity-specific sustainability framework, but it focused specifically on the supply chain. So this sustainability roadmap is the one which has been comprehensive rather than having it piecemeal. And we did it with documentation and tools from or guided by UN aids. About the approach, this has been widely consultative in nature. We had the stakeholder engagements at all levels. We created committees right from the core team, technical working groups, steering committees, program working, domain working groups, and all these were constituted by different players, by different stakeholders. And when the documents are completed, they are taken through national dialogue or validation meetings and eventually approved by the political leadership. In terms of sustainability, we think that for our response to be sustainable, it must undergo these transformational shifts. One, from just being having political leadership only at the top, to having political leadership across the board. Not only the president speaking about it, but also having the district leadership, the technical leadership, focusing and prioritizing HIV prevention and treatment. We must transition from our response from being donor funded to being domestically funded and domestically managed. We must also have our response able to limit inequitable access and to increase universal access to quality integrated services. We must transition from weak multi-sectoral coordination to a strong multi-sectoral coordination. So coordination also is not where we would want to have it. Then the issues of social stigma and gender inequality to a situation where there is non-discrimination and a social environment that supports gender equality and equal access. And last but not least, transition from a situation where our young people are vulnerable, especially the adolescent girls and young women, to an economically and socially empowered young generation. So those are the transformations that we envision to have in the sustainability roadmap. Now, in terms of service delivery, we noted that as of December 2024, we were not on track to achieve our targets for 2030, and yet the funding has been cut. So we did scenarios and said, what does it mean if we continue, we sustain the coverages of 2024? It means that we will continue to see close to 300,000 new HIV infections happening in the next 10 years, and about 150,000 AIDS-related deaths will happen. So if we do nothing, or if we decide to sustain the services as they were in 2024, it means that more 300,000 Ugandans will die. And the implication of this is that we will not be able to end AIDS as a public health threat. Yet we will have spent 6 billion over the 10-year period. However, if we adopt the America First strategy of life-saving interventions, it means that, yes, it will help us to avert about 43,000 new HIV infections compared to if we do nothing and sustain the coverage of 2024. And we will be able, we will be able to reduce AIDS-related deaths from 151,000 to 115,000. Yet the cost of increasing to America First is just about $300 million over a 10-year period compared to what we will spend as of 2024. But the interesting one is what we call the ambitious scenario, where we scale up the full package, both prevention and treatment. Because in so doing, then we'll be able to save 102,000 would have been new infections if we sustained the 2024 coverage. So if we implement the ambitious targets, instead of 300,000 deaths, new HIV infections over a 10-year period, these will reduce to 177,000. The beauty about this is that we will achieve our goal of ending AIDS by 2030, and the cost is about 500,000 over and above the 2024 coverage. So based on that, as a country, we adopted the ambitious scenario where we continue implementing both prevention and treatment coverage. And how will this be funded? I'm happy to say that the government has already started putting in money. As soon as the executive orders came out, government released the supplementary budget of about 32 billion. 32 billion is about maybe 16 to 20 million US, a drop in the ocean, but a good gesture nevertheless. We implemented the integration of HIV into the primary healthcare services, and we intensified and finalized our sustainability roadmap, which has been approved by the steering committee and waiting to be presented to cabinet. In fact, should have been presented to cabinet, but this season is a campaign season, so priorities are elsewhere. We think that the ambitious scenario can be high. We just need to increase the health budget component. Right now it is 8% of the national budget. It needs to be increased to 10 to 15%. We think that the tax base can be expanded. There are many options coming up: the oil and mineral levy, blended financing, debt swaps. But importantly also, the national health insurance scheme and the community insurance need to take up a portion of HIV treatment costs. And of course, the options of the private-public partnership, but we can't run away from donors. Government needs to engage donors so that there is long-term commitment by donors. And therefore, the MOU with the USG is a move in the right direction. Then in terms of more health for money, we've talked about integration and mainstreaming. With the same money, you are able to reach more people. But harmonization of donor support. There has been a lot of duplication in donor funding, and we think that with harmonization, we should be able to save some funding. And some more efficiency can be gained through digital use of digital systems, electronic digital systems. So in terms of the integration, we have already moved. Government, as soon as the executive orders came out, issued a circular to all the health facilities, from the topmost to the health center 4, to start providing HIV services, irrespective of whether the people were registered with them originally or they were coming from vertical clinics. And health workers have been trained on how to provide HIV care alongside TB, hepatitis B, hypertension, diabetic clinics, and other routine and chronic care platforms. What is still outstanding, of course, is the supply chains. They are still running in parallel, but those two will need to be harmonized. And as I said, physicians and other clinical staff providing services originally not related to HIV have been trained on comprehensive care. In terms of HIV mainstreaming, we have noted that it can generate up to 10 million US dollars. The report that I am showing here, about 156 votes or government agencies receive money from government, and of those, 104 allocated money. 80% of those allocated more than or up to what was recommended. Only 42 allocated less, and they can allocate more if well guided. Only 52 did not allocate. So if we emphasize this approach, we'll be able to generate the 10 million US dollars or more towards HIV interventions that are coming from an already existing budget. Then in terms of coordination, again, this will help us to eliminate duplication. And what we are doing as government is to make sure we have revised the partnership mechanism to strengthen the coordination and minimize duplication and maximize potential for synergies. We have come up with an online tool where the non-state actors go online and register. And then we are using that tool, we are able to map them to know who is providing what and in which area. And what we are planning to do, because we know that the civil society has played an important role in delivering services where government can't. So we are planning to have a basket fund which will help the civil society to continue offering those services, but this time the contract is with government and not with development partners. Okay. So I think in the interest of time, let me quickly take you through the lessons. We have learned that integration of HIV services with TB, maternal and adolescent health and reproductive health has the potential to improve efficiency and equity and continuity of care. But we need to continue to monitor to ensure that the quality of the HIV services is not affected. We have also learned that leveraging multi-sectoral budget has potential to generate substantial resources to invest in interventions previously funded by partners. And I talked about the potential for a basket fund. We have also noted that the funding cuts have particularly affected the community-based interventions and finding alternative sources of paramount and immediate importance. And last but not least, government has to be on the lookout, because we note that the America First Global Health Security prioritizes life-saving interventions as opposed to a comprehensive package that the government has identified as something that will make us hit our goal. Thank you very much for listening to me.
You know, I gave him too much time because he was talking, and I was really. But let me tell all of you. I have a conviction in my heart that if we put condoms in every part of the country where we are sleeping, because you know, when you're a priest, you can't go to buy a condom from a pharmacy, because how would you go with a collar? But if it is in the toilet, because where you go with your God only, you pick it and use it. Some of you have talked a lot as moralists, but you're also human beings. You make mistakes and repent later. You will be saved by putting condoms in those hotels where you slept. Two, if we treated everybody who is sick with the drugs, the people will just live with this disease with very undetectable viral loads and go as far as dying at 100 without causing any problems. Lastly, but not least, then a cup of you. For these people, I thank you. Tony, please.
Good morning, colleagues. The IT team kindly load the presentation for the audience. And I'm going to share a few issues around the adaptation and ensuring that we safeguard access to HIV, TB, and malaria services for the vulnerable populations in Uganda after passing the law. The statistics there have already been mentioned by my former colleague, Dr. Bagambe. So in the interest of time, you remember the chairperson, Uganda's Commission, also mentioned the Presidential Fast Track Initiative. Around 2023, that law was passed by our parliament. And of course, we realized some changes in service delivery. Kindly move to the next presentation, please. We had some care services among the same categories of populations. And of course, reported increased reports of violence and discrimination against the key populations. And of course, that came with even some of the KP-led organizations being closed. And of course, then later they had to face challenges of funding. However, how did we respond as a country? Through the multi-sectoral approach, categorized into three. Policy and guidance. There was development of an adaptation framework to ensure continuity of services. And of course, that was followed by the formation of a rapid response team with the composition of Ministry of Health, Uganda's Commission, KP-led organization representatives, and a number of other stakeholders to ensure that those sensitize the duty bearers on how to address the situations. But also we saw Ministry of Health together with the Office of the Director of Public Prosecutions issuing circulars to the different health centers and facilities, health workers, but also people in the judicial service to ensure that they provide guidance and ensure that the KPs remain served. The other part was around the stakeholder engagement. We saw a lot of community action, community-led action to ensure that the rights-based law enforcement is done, but also the mentorships and supervision targeting health workers. Next slide, please. This is just a pictorial, just for you to know. The very first one where there is a red, that's the chairperson of the Parliamentary Committee on HIV. So there was a lot of involvement and support from the political leadership, but also the technical leadership. Next slide, please. The Minister for Presidency, again, sensitizing the members of the criminal justice system to ensure that they understand how to address the issues, but not just to criminalize the victims. And of course, the officials and the leadership in the police were heavily involved and engaged to appreciate what exactly is expected of them. Next slide. This is just a copy of the circular that I mentioned from the Ministry of Health. Next slide. And then the circular from the Director of Public Prosecutions, again providing guidance on what is expected. Next slide. So what did that result into at the end of the day? So dialogues were made, circulars were issued, you know, a number of stakeholders were involved. And of course, over time, between June to December 2023, there were of course some cases of evictions because of the law, but that came down by about July to December 2024, and the period January to June this year, we realized that actually the trends were changing. And when it comes to service delivery, again, you can see the statistics between January to June 2023 and July to December 2023, where we had quite a big drop. And then eventually, because of these interventions, people were again put back to service. And of course, you see the trends going up. And of course, through these processes, we've been able to learn lessons as a country. One of these is to see that service continuity is possible amidst legal disruptions. So we may not deal with the legal disruptions, but of course, ensuring that service delivery continues, that is key. The other key point is that the strong coordination among the different stakeholders, like you've seen even in the pictorials, that is important to ensure that we address the disruptions that are created. The duty bearer sensitization reduces harmful interpretations of the different provisions in the law. That was important. And then, of course, key to note is that communities remain central in sustaining access to services. The communities were heavily involved. And of course, Uganda's approach, we believe, is something that can also be replicated as a lesson, even in other regions where such takes place. And lastly, we remain committed as a country to ensure there is uninterrupted access to HIV, TB, and malaria services for all, amidst, regardless of the gender, identity, and legal environment. I thank you so much.
Clap for him. You know, I was an MP. So when you see me here I am too gentle. Now, when I was an MP, I was one of those violent MPs because I used to deliver women in cars in the hospital where I was working. And one time I went to the medical superintendent. I said, the medical superintendent, I'm conducting deliveries without gloves because women are pushing kids, they're going to die. What do I do? The guy said, you go and ask the president. The following morning, I was standing. I danced for drunkards. I became a parliamentarian, and I can tell you, I gave them a headache. So everybody inside here, I want you to know that to become a doctor, you study for 6 years and even do internship. To become a parliamentarian in some countries, you only need a Senior 6 certificate. So you can imagine the fate of Ugandans and other people is being determined by Senior 6 dropouts. and that's why things go wrong. Let me tell you something. In that law, some things were removed, but it was a bit funny because they said if any doctor is seen treating somebody who is from that side is a criminal. Really, I am a doctor. You have come to me. Even now in this room, I don't know who sleeps with who, and I don't want to know actually. Whether you are sleeping with a man, it's up to you. It's your life, it's not mine. If you have a wife, I don't care. If you have opted not to marry, it's okay. There's no problem. You can even sleep facing down. I have nothing to do within that bed. But should you come to my clinic, I will give you treatment. And that's what we said. That for us as doctors, we are okay. I have nothing to. Then when I treat a patient that I didn't now take you to police. No, policeman, really? I don't know whether there's some policemen in this room. How many doctors, how many intestines of human beings have you seen? Or how many uteri of women have you cut to remove children? Then you start putting a lot of things on me that in case I treat somebody who sleeps with a man, you should put him in prison. For what? So me, I treat. And by the way, I have a mini hospital in Mbarara, in town, in Kampala. So everybody, when you are traveling, come to my clinic, I'll give you treatment. We have no problem. But these guys are here. I think we have to have some interaction. This is a very important thing for us. I don't know whether in some of your countries you have similar issues. But for us in Uganda, we have opted to continue. That law, the policemen, they have nothing to do because they are in their police headquarters. People are doing their own things. And you have seen even things have gone down. We have opted to say, let us move on. 3, learn how to tell politicians the truth. Don't fear them, they're not God. We must get money to treat our people if we want to lead them. This nonsense of, man, Trump has cut money, let him cut it. In fact, I'm happy he cut it. Because when shall we ever get up? This slavery mentality must stop in this world, that you cannot, even giving somebody something to use, you must go to look for a donor. For you, what do you want to give to yourself? It's like producing a child and you can't provide food. You are an idiot. We are not idiots in this thing of treatment. We should be able to treat the people that are in our hands. So for me, that is the gospel according to the chairman of the system of Uganda. And let me tell you something. When I became chairperson of the system of Uganda, we had never had money. Because every money running system was from donors. Me, I moved. I told you don't know what I am. I am a very small boy, only 80 kilograms. So I drove my car. I went to the permanent secretary, Minister of Finance. I said, I want the money. He said, how much do you want? I said, I want 4 billion. He said, it is impossible. I said, if you don't want, I'm going to leave. If people die, I don't know what you tell the president. Emma said, you come and we'll talk. I went again. So I gave him things. And I went with actually donors. I said, donors don't speak because this thing, you don't know it. Let me talk about it as a Ugandan. If they shoot me, I will die for the country. Do you know what happened? The following week, they gave me 4 billion. I got the money. So the CCM, Reverend Jamucha, I got money for CCM. There is money for running and coordinating these things. I did the HIV law. We are supposed to be putting money in a basket to cater for these things in case they don't have a cut. Somebody will not give you food forever. For us as a country, we have opted to tell our president the truth, but good enough, he was a very good guy. You see him, he has stayed a bit longer. But for us, when the money was cut, he gave us the money. So we believe that Uganda as a country, with or without donor money, Ugandans will not die when we are watching. We can tell you we shall not sleep and everybody will get treatment. We are not saying people should not help us. They can help us. But in case they really want us to go, we shall not die. We shall help ourselves. And Uganda has recently have a lot of oil. So in 2026, it will be out of the soil. Trust us. We will just treat ourselves and even our neighbors. Now, for some of you from our neighboring countries, you have seen Uganda is landlocked, but we are land linked. Yes, because we are in the middle of the East African bloc. We can go to Tanzania, you just drive, you go to Kenya, you drive, you go to Congo, you just drive, you go to South Sudan. We just drive. If we want to fly, fly. We have planes. Trust us. If this oil comes out of the soil, we will even help our neighbors, because in Uganda, people can come from anywhere and we can, because there are some intermediaries. Now, I want us to have a simple dialogue. The guys are here. You can ask them, do you want me to push them for yourself, for you, or you want to push? You have some questions for them? Please. Let them, give him a microphone. You'd say your name, where you are coming from, so that I can know whether your country is willing to do what Uganda is doing.
All right, thank you very much. I'm Washington. I'm from Malawi. So my question is directed to, is it Dr. Bagambe? Yes, in your presentation, you mentioned an issue regarding having a harmonized donor funds. I just wanted to learn from you, how are you envisaging to implement this, taking into consideration that donors have specific interests and specific areas? Thank you.
Can we have about 2 more questions? Baganda, please. That now that the people are going away, and they have, some of them have what interests? But how are you harmonizing? You are from where? From Malawi? Perfect. Chambo. So the Malawian is asking you. You'll tell him. Another person?
Okay. Good morning, everyone.
Yes,
my name is Kenneth Sakavira from Uganda.
Yes.
I have a question for Dr. You've talked about social stigma, and wondering whether the Uganda AIDS Commission has got data on both internalized stigma but also external stigma, and what is the approach on addressing this as its key concern in the response to it. So I'd love to know if the Uganda AIDS Commission has got some data to help us. I work with an organization called TACO, and we're working on programs to address stigma for young people living with HIV. Thank you.
Is there another person? Yeah. I told you this thing is very sweet. Don't worry.
Yeah.
Your name?
Good morning. My name is Raphael. I'm actually your neighbor from Tanzania.
Perfect.
Yeah.
Karibu.
Asante sana. So my question is to the last presenter on the Anti-Homosexuality Act. So I was actually interested to know if that act was publicized to the country that it's a criminal offense for people to practice homosexuality, and what strategies did you use to ensure these homosexuals that they are still safe to access the health services? Thank you.
Thank you so much, Tanzania. Tony, that one is your question. Let us hear from Uganda.
Thank you so much. Good morning, everyone. And thank you so much, our leaders from Uganda, for the wonderful presentations. My name is Grace Naiga. I'm the Executive Director of Uganet. I come from Uganda. One of the things I learned this week from one of the presenters, they said, it's a Nigerian quote that says, even when you cannot hear sounds, you can tell when there is war. And I just want to say that the legal environment in the country is really a disturbing one. The CCM representative has talked about but just for us to acknowledge that we are one of those countries that criminalize people living with HIV, and that's a law that we enacted in 2015. And probably Chairperson CCM, it might be true that it's because of the caliber of MPs that we send to our parliament. So it's one of those problems that we still struggle with. And we are worried that if the trend continues, we'll see the sexual offences bill, we'll see the marriage bill pass in the state in which they are now, and that will mean more trouble for women and girls, for sex workers and the other groups that oftentimes find themselves disabled by the legal environment and the policies that we have. But my question is specifically to Mary, and I wanted to hear from her as someone at an international level, how we can deal with the pushback around the women's rights. Throughout this conference, there's been conversations around eliminating vertical transmission. And I believe one of the issues that are impeding that elimination have to do with gender-based violence for women and girls. In my country, we have a young population. Many of them are on social media. Recently, we had a doctor coming out and saying that women no longer want to give birth, and as a result, that's why they are having fibroids. And it was a big fight for the feminists and the other women on social media, and you could see that women still struggle with having and holding that place in society. So we ask ourselves, amidst the global pushback, the anti-rights on women and girls, how do we ensure that they are protected so that in turn they are able to access services and we eliminate some of the issues like vertical transmission? I thank you.
I think what we do, I take note of you, and you let us first of all answer this, and then we just go to, But you people, let me. I told you I was an MP. For you, I would never have been there. There is a woman in Uganda. She didn't have a husband. I heard she had some issues with her husband, so they divorced. The woman came and said she wants to do the so-called marriage and divorce bill. In that bill, there was something very interesting. That if you're my wife and I am within a bed, and in a way the head is working, and I ask you, things either happen or they refuse, that you should sue me. Now, when you sue me that I raped you as my wife, who will be the witness? There was said, but this is nonsense. How do you start telling? When we went to consult women, they threw stones at us. We went to villages to consult all the women who have been there. We said that the women are saying husbands are raping. So the woman asked us, that you think my husband to rape me, I don't want it. So we are struggling with it. They said, can you go out of here immediately? So the old women ran after us with sticks, who are MPs. Women almost killed us, that were fooling them. They said, you don't have anything else to talk about. so we have seen things. Now, that one put aside. MPs, they are in a world of their own. They can do any law. I don't know. And some of these laws are very sentimental. You have an issue with your husband, you're a very bad person. You are either a bad husband or a bad wife. They come to parliament to revenge by producing a very bad law to disturb us. People are very happy to marry. If you are fighting with your husband, you go and sort out yourselves. There are women who want to sleep with their husband every evening. They are there, they say, me, I want. How do you say that somebody has been raped? Now, time.
Okay, thank you very much, Chair, and thank you for for the comments. I think I will respond to on harmonization question from our colleague from Malawi. Yes, so we have, and I think I hinted on it, we have identified as government the priorities that we should invest in to have a comprehensive response. And then partners who come, they come with what they think they can contribute, and we negotiate. The example that is happening now is, of course, the negotiation with the USG. What we are noting is that the USG is coming with also interests that are a little bit tricky, because they are saying that, yes, we'll give you the money, but buy from our manufacturers. And yet, we also have a young local manufacturing industry that we want to grow. So we think that as a government, in the negotiations, so we will say, yes, okay, as long as you are giving us your money, buy from your manufacturers. But remember, it's a sliding scale. What they are giving us in year 1 is not what they will give us in year 5. As you pull out, we'll be buying from our manufacturers. So in other words, we will have to set our own terms as they set their terms, and what they give us, so long as it is benefiting our people, we take it. If it's not, then we put our foot down and say, no, this is the direction we are going to.
Then on social stigma?
On social,
Sekabira.
Sekabira about
data on social stigma, internal and external.
Yes, each year we do a stigma index survey. The last one was done actually Makerere University School of Public Health. The report is there. Working with the Global Fund, I think there is another one that is planned. And then, as Uganda AIDS Commission, we developed a stigma and discrimination manual and guidelines. So that helps you to identify which stigma and discrimination interventions you need to apply for the different groups. So when we go back, we can give you a copy of that. Right now, it was also undergoing a review. Maybe you can be part of the
But
team.
can you
that is
refer
doing
him to
the
some
review.
website? Are
At
they
the
on
Uganda AIDS Commission website, we have it.
Perfect. Let us go to Rafael. Rafael TZ says the actone, has it been taught to people to know what it means so that when they are voting, they vote for substance? This is the thing.
Thank you so much. Thank you so much, session chair and the colleague for the comment. Yes, there was a bit of sensitization to a certain extent in the country. But of course, like I said, and you remember the dialogues that we talked about that happened, especially with the law enforcement, yeah? Those helped us a lot to ensure that even when the sensitizations happen, at least there is clear understanding of the provisions and what they mean for the law enforcers, but importantly, for the population. And of course, we've seen as a result of that, the reduction in evictions and criminalizations and things like that. So what we've seen and what we've learned is that there is always, when a law is passed, of course, everyone will interpret it their way. But of course, with time, it takes learning and unlearning, which has happened, especially in our law enforcement systems. And the situation is now different. Thanks.
In other words, they put the law is sleeping. We cannot follow that thing because it is very funny. First of all, you start going to lodges to look for men who are sleeping with men. Where will you get them? You start bringing people's rooms. They went and spoke their things there. Woo! The law is dying. That's the whole thing. I'm telling you. Because you can't catch anybody, whether they want to or not. Now, the thing of Uganet. She was asking Madame Mary Mahi, but you can help her because she's not online. But can you answer that?
No, maybe we will put the question to her and then they will be able to give us a response.
Yes.
Yeah, she had sent a recorded presentation.
Yes.
And this morning, so she said any questions, we can capture it. And
my guy is saying, how can we push back and we fight on? Because these laws, she's not understanding there. But don't worry. Yes, maybe.
I just want to say something a little on the AHA. Now, when discussions are going on about the law before it is put into practice, I think there's a lot of talk and a lot of publications about what is in the law, which eventually is not in the law. So we also have to take account of that a lot of what was discussed before the law was passed is not what is in the law. So most people know what was discussed and they feel like Uganda is a terrible place because of the AHA. But on the other hand, it is our duty as Uganet, Uganda AIDS Commission, to know what is there that is not helping us, which needs to be changed. And that is what we do as Uganda AIDS Commission. So you bring to our attention, we also know the parts of the law that are not doing well, are not supposed to be there, so that we advocate for them to be removed. And I think that is always has been our job.
And yeah, by the way, our president was very precise on these things. He said, but why do you go into these laws? Why are you doing these funny things? Finally, he told us that he's only, if you want to come to Uganda to start looking for our children, to put in those things, you can't manage there because the culture there will finish you off. But if you come as an adult and you want to do your things with adults, please come and enjoy yourselves. We have no problem. What we cannot allow in Uganda is you coming and taking my own kid of 18 years or below. If you go there and I don't believe in it, it becomes a very big problem. But for adults, please go ahead and do your things. We cannot control you. Guys, it has been nice being with you. I think you have seen how Uganda does things. And please come over and visit us. It's very short from here to Uganda. It's very easy. You go to Addis Ababa, you cross. You go to Entebbe, 2 hours. You go to Nairobi, to Kampala, it is only 45 minutes on a plane. There is even road network. And Uganda is a very good country. Let nobody ever tell that we're not bad guys if you can look at us. And we thank you in the Karibu once again for coming. I thank you. Let me appreciate this team I have come with. Thank you so much, our senior, Dr. Ruth, for being with us, and Dr. Bagambe and Tony for making this place a bit colorful.